Okay, welcome. Today we want to talk about surgery, how surgery's changed, what surgery used to be focused on, what we're focusing surgery on now, and that airway connection, and how this mimics orthotropics and what we've been saying in orthotropics for many, many years. Now, I'm joined today by two really excellent clinicians and lecturers, and I'd say great thinkers within this small sphere. So today I want to introduce facial changes in airway surgery and the orthotropic connection. Okay, I'd like to start with introducing Simon Wong. Simon, the next slide. So I've known Simon for about 15 years now, and he really is a leading expert in facial growth guidance. He runs a clinic in Melbourne. He's involved with surgery in Valencia. And over the past 12 years, he's been running this clinic that he's developed. And I would say that if anyone is challenging me with gaining good facial changes, it's Simon. He is everything that I'm not. You know, he's studious, he's focused, he's able to really think well around this subject. He helped write the book Jaws, the Jaw Epidemic, and he's currently doing some, fantastic research in the University of Alberta and Texas, where they're literally he's taken every single cases. Simon, what is 140 you've got now, is it?
Over 150 consecutively started.
Over cases. 150 consecutively started cases. No one anywhere in orthodontics is doing such consistent research. That really that's something I couldn't do. That takes absolute focus over years to get that type of research. And that then, when you have consecutive research, you see what's really happening. Listen, Simon, pleasure to have you on. I'm also joined by John Flutter, that for many of you needs no introduction. I'm regularly doing things with John, and I think he's one of the best lecturers on the circuit. Anyway, Simon, so let's move to the next slide. What have you got to present for us today?
Yes, so I guess a good place to start is the start of the shift in the way surgeons thought about how to move the jaws in surgery. Larry Walford was the creator of the counterclockwise movement of both jaws to shift the occlusal plane into what he felt to be a more natural growth direction. I know, Mike, you want us to consider that concept of an upswung versus a downswung face.
Facial form, yeah.
Orthotropics is trying to achieve normalized growth, which upswings the facial complex. And Larry Walford thought that this had to be the way he had to set faces. So one of the things about vertical growth, if we look at slide A and slide B, this is the presenting facial form of this young 14-year-old. And you'll see that the chin is receded. It's very hard for this girl to have her lips together.
Yeah.
Her maxilla is in what we call vertical excess, so very gummy.
Yes.
And her whole face is swinging downwards towards her chest. And Larry understood that normal growth, we all start off in that infant form, and as we mature, our face swings up and forward. And he thought, well, if that's how we grow normally, shouldn't I set a face to be normal if I want to correct all the distortions? So prior to Larry Walford, the focus was on teeth, exclusively on teeth. And it didn't matter where the face ended so long as the teeth lined up. But Larry's uniqueness was that he wanted people who he felt had so many disfigurements in the balance of their face that they couldn't live a normal life. And he thought, I want to not only get the teeth lined up, but I want that face to be normalized. And what he did was he considered what was important, and he realized that the face was important.
Can you show us the pictures of those faces that he has? We've got the photographs next of the Larry Walford faces, haven't we? Can we see what we mean by that?
Yes. So what Larry realized was, in order to get a face to fit within a normalized view of what is attractive in society, certain characteristics were required. You needed an occlusal plane that was set about 8 degrees, 8 degrees to Frankfurt horizontal.
Okay.
And he realized that people who needed surgery, orthodontic surgery, almost never had that occlusal plane angle.
Yeah.
So this angle here, she had a 20-degree occlusal plane.
Right.
So that's from the eye to the ear as horizon, and an angle of where the teeth meet is 20 degrees. And he thought normal people have approximately an 8-degree angle.
Yeah.
So he said, that's what I'm going to do.
Yeah.
This was the surgery that he created.
Yeah.
And this was 21 months post-operative.
Yeah.
And figure E is comparing the two of them.
And figure E is what we call the superimposition, where you put one over the other. And you'll see that she gained an enormous movement in her chin, upwards and forwards. And visually,
it makes a
the
nice
face completely transforms.
Yeah, nice improvement.
But would we say at this point, although the airway may or may not have improved, that wasn't the focus early on when he started?
No, I don't think the decision at that time was based entirely on the airway. He did realize that when you upswing the face, the airway tends to increase in its physical dimension.
Yeah.
But if you downswing the face, because a lot of surgeries prior to the 90s was what we call clockwise rotation, the changes moved from being teeth focused to airway focused. When you bring the jaws up and forward in an upswing, then you will allow the tongue more room in the mouth.
Yeah.
And the back of the tongue being the front of the throat,
yes,
it gives the potential for that airway to increase in its dimension.
Yes.
So one of the things that surgeons did routinely in the 1900s was that they moved small segments of the jaws. And what they would do is they would cut the maxilla, the upper jaw, into 3 parts. And they would also cut the lower jaw into 3 parts. And they would basically shuffle those 6 parts around, 3 on the top, 3 on the bottom, into a better position. They would then bolt using screws, all the section parts together, and allow it to heal. When they actually evaluated the physical improvements, there was still issues that were unresolved. And they realized moving the bones around didn't stop the throat from closing up at night.
Yeah.
And all that surgery was wasted.
Yeah. So we're saying now they've got the better right. Whether we're starting to move the faces up and forwards, that's certainly helping. That's what
Absolutely.
Larry Walford interjected.
It
Now,
made it big.
saying that if you're doing these 3-part maxillas, we're not getting everything further forwards because you're leaving the back bit behind.
He came to the realization that if you cut things up into little pieces and move them around, you could make them superficially look good. But it didn't really change how the body interacted soft tissue with hard tissue. The tongue, the soft palate, the throat around that area. And he realized that despite this amazing space that they created, it all kind of collapsed at night, roughly at this level here.
In the throat.
Just under the chin, at what we call the hyoid level.
Okay.
So was that when you realised that when you were bringing the teeth forwards, you weren't bringing the soft palate forward as well? Is that when you realised you had to bring the back of the mouth forwards along with the bones, the soft palate in particular?
Yeah.
That's correct. That is absolutely correct.
If you didn't bring the soft palate forward, you weren't raising the tension in the whole of this area, basically tensing up the airway. If you don't,
Absolutely.
It's just basically a soft tissue space. And if the soft tissue is not pulled out tight, it's going to collapse down.
Yes, absolutely. So like a tent, poles and the guy ropes. You can make short tent poles longer, but if you don't pull the guy ropes tight, it won't hold up the fabric. So he thought, if the top jaw was moved in one piece, that would pull the soft palate forward.
Yes.
And what he did was, he thought, I'm going to break up the surgery into 2 parts.
Yep.
I'm going to make it wider first, let it heal, and then I'm going to bring a wide jaw forward. So what he did was he put a screw that he bolted into
like the MSE
palate.
technique.
Absolutely. And he released the top jaw in the midline and along the sides.
Yeah.
And then he got the patient to turn the screw until it reached the width that they wanted. And then they would let it heal over 9 to 12 months.
Yeah. So effectively, he's done like a surgically assisted MSE expansion. So not only does he put the 4 TADs into the roof of the mouth and use an expander, but he's also then gone and cut off some of the other connections, so he's made surgical cuts around so that this area of the face could expand really well as his first procedure.
Absolutely.
Okay.
And it was very interesting. When I learnt of this, I thought of the orthotropic stage 1.
Yeah. Yes.
Where your first goal is to make the top jaw wider. And one of the things I always thought about was, well, why is the top jaw the first jaw that you work on? I asked John, he said, well, that's the one that matures the fastest. So you really do need to get on with it. Because the mandible grows for many, many decades, whereas the maxilla only has 1 decade for you to work on if you're doing orthotropics. So Stanley New thought, I don't want to start doing surgical planning using man-made concepts. I don't want to artificially cut the body apart and then piece it together in a way that I feel is appropriate. I want to copy what nature does best. And those were his words. I was privileged enough to show him my cases. And the first thing he said was, your work validates mine. Because what I'm doing is I'm asking my colleagues to believe in me. So he changed the sequence of treatment. Instead of doing it all in one go because that's convenient, he broke it up into phases that mimicked how a child would grow normally, where the top jaw would grow wider first and then slowly move forward, and then the bottom would catch up in time. So he broke his surgery into the upper, what he called the dome technique. He would let it heal. And then once it was healed, he would bring both jaws in that counterclockwise upswing movement. And because he wasn't
long distance, Simon, here, I'm looking at that.
Absolutely. One of the things that limit how far you can pull a face forward is if you want to widen at the same time. If you want to widen, you can't pull it that far forward because you're trying to move three separate pieces.
Yes.
But if you're just pulling it up and forward, then you can bring it 1 centimeter, 2 centimeters, 2.5 centimeters. He was telling me, he's gotten 2.5 centimeter movements in some cases.
Yeah.
And how does that relate the maxillary, the upper arch with the forehead? What was he doing with, how did you see that change there?
Well, when you are trying to improve the airway, you have to understand, this is a concept that John Mew taught me. He said, Simon, when you widen the upper jaw, your goal is to make sure you have room for all the front teeth. When you bring the jaws forward, Simon, he said, you are aiming to make room for the back teeth. But when you swing that complex up, you're making room for the tongue to live in the mouth so it doesn't have to crowd the throat.
Another way I'm often saying this, everyone's into expansion now. Expansion for the airway, expansion for the teeth, expansion for looking good. But if you're going to increase the cross-sectional area, which is what we're doing, expansion, you've got to reduce the vertical. You've got to be consistent. So all of these people are just willy-nilly expanding, but unless you're going to either decrease the vertical or try to decrease the vertical, so affect the factors controlling the vertical, you're not being consistent and you're going to leave teeth out their balance zone.
It's three-dimensional, right? There's width, there's depth, but there's height. And actually there's a fourth dimension too, isn't there? Time, right? The 4 dimensions of our life. And time, see, here's a concept that I want people to understand. You cannot expand your way out of a depth problem.
Yeah,
and you cannot protract your way out of a height problem. And you cannot outweight a time problem.
Yeah. And we've all got, I always reminded by the fact that sleep apnea wasn't in my syllabus when I qualified as a dentist in 93. And from one top consultant I talked to last year, he said he thought 20% of the adult population in westernized countries are going to die a decade early because of sleep apnea. Now, everything heads south in time. I'm sorry, that's the way it's going to go. Now, unless you're significantly up, you've got problems coming up in the rearview mirror. Okay.
Absolutely.
Please continue.
And the other thing I think is important with sleep apnea, which is why I think it needs focusing on so much more, is the effect it has on intellectual development of young children.
Yeah.
I mean, the brain needs oxygen at night,
yeah.
and sleep apnea denies it of oxygen at night.
It's Stephen Sheldon in Chicago saying there's no such thing as ADHD. These are kids who can't sleep properly because their faces haven't grown properly. And isn't it interesting? We've got this rapid rise in all of these spectral things. We see this rapid rise in malocclusion. We've got this rapid rise in sleep apnea and a rapid rise in these behavioral issues, these spectral
neurodiversity, they call it, I think.
I just wonder if it's not all connected. If the question has to be asked. Sorry, Simon, please do continue.
No, I would agree on that point. When we were growing up, we chanted our little ditty. The knee bone is connected to the thigh bone. The thigh bone is connected to the hip bone, and
it's all connected.
It's all connected.
Can you show us an example of the sort of facial changes he made once he started doing surgery like this? He also got some significant facial changes associated with it.
Well, Stanley said, my goal was to get a non-collapsible large airway. And he said, the interesting side effect of that particular goal's achievement, you also got an extremely attractive face.
Yeah. So Simon, so sum that up again. You said the side effect of improving the face for health characteristics is to make it look good, to make it look attractive.
The only way you can get all the teeth in, the tongue in the mouth and not in the throat, and an airway that doesn't collapse at night is to create a really good looking face.
Yeah. Now, Simon, this looks like, I used to term this a bio-block, we still do, a bio-block face. My entire life, my father's been pointing out people that have grown well, grown like this gentleman on the right-hand side, and said, that's a bio-block face. Bio-block being the orthotropic method we do in Pearly. And this is, when I was younger and I would come up to meet my father and we would walk around, his clinic in the local area, we'd go down to shops or we'd go down to see something. We would bump into people, usually guys with these big square faces, and Dad would go, oh, that's a patient of mine. Then you'd walk, there's another guy with this, really solid face and go, oh, there's another patient of mine. And those were the days when, he used to get local custom. And it was, they were walking around evidently to see all of these faces that look just like that case you've showed me. Just like it.
The nature of good growth expresses itself as attractiveness to those around you.
Yeah, we're hardwired to be attracted to healthy people.
So can we then move on? We've discussed how surgery's changed from focusing on teeth to more of a focus on airway, and how the surgical techniques changed in order to get a better airway and a better face and better teeth. And then perhaps we can look how we were talking about how that mimics or copies what orthotropics does in doing the same sort of thing. And so we can look at what John Mew was suggesting and what he was been talking about for the last 50 years, some 40 years before these surgeons came up with the same sort of realization.
So one of the most important concepts that John Mew taught me was that malocclusion was an environmentally driven outcome.
Yeah.
And he told me that the oral posture, how a person holds their mouth at rest, determined the direction of the growth, whether it was a downswung face or whether it was an upswung face, whether it was a forward rotator or a backward rotator. And he seemed like a lone voice in the wilderness. But when you look at research, when you look at science that is being done at top-tiered universities, you realize that these concepts are not singular to John Mew. These concepts are, in fact, reality. Peter Bushang is probably the lead researcher in the world on posture. And his concept of understanding was, I'll read it out, the etiology of hyperdivergent Rethananthia, which is a long face with a weak chin, like that first girl we saw in Larry Walford's case. 20
with the 20 degree.
Yes. The etiology appears to be environmental due to postural adjustments related with compromised airways and weak masticatory musculature. So small throats and weak chewing power.
Yeah.
Posture creates a long face with poor airways.
Yeah.
John started his journey 50 years ago, and he worked on clinical patients and he researched his work. And not only did he realize that poor posture created long faces that had poorer airways and crowding for the teeth, but he realized that the techniques we in orthodontics use can also influence how the teenager might finish their growth. And he worked out that if you put braces on a child, their teeth may get straighter, but it might lengthen the last few years of facial growth.
Yeah, that's a big controversial issue, isn't it, Simon? You know, whether or not orthodontics can at times lengthen faces.
But what we do know is postural orthotropics can control facial height.
By understanding the causes of the problem.
By understanding the causes.
Cool.
So I started to employ pearly orthotropics in my practice. I started to use bioblock orthotropics, and I was able to help young children who were vertical, downswung, hyperdivergent with weak chins, change the direction of their growth pattern by focusing on widening the maxilla, driving forward growth, and giving 3, 4, 5 years of time in a bioblock appliance, which enforced a closed mouth resting posture.
So I was going to say enforcing. So we're talking about an appliance here that if you drop your jaw down, it touches the skin, potentially being uncomfortable. So it reminds you to keep your jaw raised up, which is elevating your tongue, which is just affecting some, but not all, some of the causes of the problem.
The other thing I think is important to make, the important feature to make about the BioBlock Stage 3, which is what this appliance is called, it's an appliance that works on the upper and lower jaw at the same time. And there are many appliances like that, but its unique characteristic is it has no reciprocal effect on the upper jaw, because the child has to hold the mouth closed under their own muscle effort. It's not mechanically handing the mandible off the maxilla. They have to develop their own musculature to hold their mouth closed. And then if their mouth drops open, then there's a reminder to keep their mouth closed, because there's some discomfort inside the mouth. I think that's the distinguishing feature of the BioBlock Stage 3 over appliances like the Bionator and the Twin Block.
All of these other functional appliances. I mean, it's a postural appliance. It's not a functional appliance. And you can't confuse the two of them together. You know, the Twin Blocks.
The point I was making is that they are confused. They are
too often they are
in the same category, but they are different because there's no reciprocal force on the upper jaw.
This appliance sets up a Pavlovian feedback cycle. So you drop your jaw down, it's uncomfortable. You don't drop your jaw down. You're changing a behavior. You're changing a pattern of behavior rather than literally holding the jaws forwards and only doing that when people close their mouths. It's very easy to wear all of those other appliances you mentioned, John, like this.
Absolutely. So what we're saying is that the very thing the surgeons were trying to do, then Simon, learning from John Mew, has perfected some of John Mew's techniques and is doing the same thing in younger children, getting to grow and change the growth patterns in the same way that the surgeons are now trying to do surgically, which is essentially bringing the whole upper jaw forward and the soft tissues and the tonsils to improve airway, to get straighter teeth, and inevitably, as a result of that, they'll have a more attractive face.
Yes.
Can we see the change it's made on the airway that you get at the air when we see the change? So you've achieved the same in the airway, you've achieved the same in the facial form, and the same in the positioning, and that mandibular plane angle that you were talking about have all changed in the same way that surgery would have done in an adult.
What we know is, see, people have to understand that the combination effect of where everything is relative to everything else is very, very important. You know, people can very easily discern if you're wide enough, because we look at each other front on, we look at ourselves in the mirror. So it's very clear. If you're narrow, it's obvious that there's something not right. But the profile of a person can be very difficult to discern when you're not trained. So I'm going to give everyone a very quick lesson on how to determine what is the appropriate depth of the face. The first question is, are they even? Are the two jaws even? Are they in line? Is one like a bulldog or is one like a goofy dog?
Yeah.
The question is, how do we know which one is the correct jaw?
Yeah, exactly.
And the answer is very simple. If we use the forehead as the reference point, if your jaws are in front of your forehead, your wisdom teeth will fit. If your jaws are in line with your forehead, your wisdom teeth will not fit. If your jaws are behind the forehead, a whole stack of your teeth won't fit. A simple way of making a very easy diagnosis. So can we see here in the 8-year-old, her top jaw was in line with her forehead, but her bottom jaw was behind.
Now, I will say, Simon, here, the foreheads are at slightly different angles. You know, and I notice there's a lot, and this happens, it's almost universal. As soon as you improve someone's craniofacial development, maybe it's as they get older, they tend to stand up straighter. So those foreheads are at slightly different angles, aren't they?
Absolutely. Which is one of the reasons why in orthodontics, we also take x-rays. Yeah. So that we can superimpose them correctly, that we can take measurements correctly. Mm-hmm. Now, if we look on an x-ray, we can see the top jaw is in line, if not slightly ahead of the forehead, and the bottom jaw behind. But in
after treatment,
it's quite clear both jaws are in line and well ahead of the forehead.
You really have moved that face forwards.
And what we call the vertical dimension, the y-axis, so we're using the ear and the eye as a horizontal reference, horizon. Yeah. What's the angle of that, where the teeth meet? What's the angle of that lower jaw? And is it possible in what we call a hyperdivergent child for them to change that direction of orientation? And the answer in the research says, no, generally they get worse in time. Yeah. And after orthotropic treatment, in this particular case, not only do we bring both jaws in line with each other, but we brought them both in line with each other ahead of the forehead, and we upswung the vertical dimension.
Yeah, very true. That's what we want to be doing.
So when we look at the distance in that area, we can see as we get older and our jaw swings up and forward.
And we gain this nice improvement in facial growth.
Is improved. Because, you know, people look at this part here and think, oh, yeah, how much has that improved? People don't look at the first blockage, which is at the adenoids.
Yeah.
And if you aren't bringing that soft palate and the maxilla forward, then you're not going to get an increase in the flow of air at the adenoids level.
Yeah, this is that second blockage you were talking about with Stanley Liu saying you've got to move that soft palate forward. Simon, can you just point the soft palate out on the X-ray?
So this is the hard palate.
Yeah.
Above the teeth. And this extension is what we call the soft palate, which is the dangly bit that everyone gags on at the back.
Yeah, and the bit that makes that noise when you're snoring.
Vibrates when you snore.
Yeah, because you move that way forwards, it ain't vibrating anymore. It's out of the path of the air. You're not going to snore. You know that phrase, snoring today, sleep apnea tomorrow.
But by making the airway bigger, the air passing through it is less turbulent. It's the turbulence of the air in the narrowness of the airway that causes the soft tissue, the soft palate to vibrate, which is snoring, isn't it?
The collapsibility of that airway is determined by whether the tongue is resting on the palate or not. Now, everyone is aware of the hard palate. But everyone forgets the soft palate is also the palate. When the soft palate is resting against the back of the top of that tongue, it stops vibrating because it
can't vibrate. If the tongue's up on the roof of the mouth, the back of the palate can't vibrate. It's a very good point, Simon. But there needs to be space for that back third to get up there properly. Because there's no space for that back third to get up there. It can't get up there because otherwise it's going to block the airway. And if you block the airway, you're not going to have a happy time.
Absolutely. So one of the big concerns that I have with the adult community who is trying to use posture alone.
All these adult mewers.
To improve their airway will actually create an environment where they increase their sleep apnea.
It's an interesting point. An interesting point. You know, I've said, I've said I know how mewing works for me. This is not a subject that's been really massively researched. It needs it. It needs it badly. In fact, in many ways, mewing is an extension of my functional therapy.
We've been told the end game goal is to rest with your tongue on the palate. We have forgotten that palate includes the soft palate. And unless your jaws are sufficiently sized and sufficiently positioned forwards and upwards, if you attempt to rest your tongue fully on the palate, you will actually force your tongue against the back of your throat. You will force your soft palate against the front of your tongue. You make a very good
point, Simon.
Of your adenoids.
Mewers, be aware of this. Be cautious. And as I said, this is when you might consider getting some expansion to help yourself. Improve that cross-sectional area so you can get your tongue up there.
So that's just the only point that I wanted to bring up.
Yeah.
And would you like to then, Simon, show the last slide, which is your work that you do, and summarize and wrap this up for us?
Thank you, John. Well, one of the tasks that both John and Mike have entrusted to me is to continue the education of the dental community who are interested in learning about orthotropics. And one of the things that I did was I created a program that sat within the dental community's accepted parameters.
Yes.
There are orthodontic standard of care requirements whenever we treat children with orthodontics. And what I realized was the single most important aspect of treating children is to maintain safety. Safety for the child's health, safety for the child's growth, safety for the child's dental alignment, and safety for the clinician in providing care that improved and did not take away in any negative sense. Orthotropics is not a discipline, not a routine discipline within dentistry. And as such, it cannot be learnt on a weekend course. Realistically, you would need 3-4 year master's program to really get a handle on orthotropics. Full-time, 3-year tertiary education master's program. At the moment, that type of program doesn't exist. No. So what I did was I created a 2-year program for dentists to introduce them to concepts of posture and how that it might help with their orthodontic practice. And the first 2 days of this 2-year program is a 2-day introduction to postural orthodontics. And it's a new evidence-based approach to early intervention orthodontics. And I'm running it via Zoom on Saturday and Sunday, the 16th and 17th of July this year. And that information is available on straightteethnaturally.com. And amongst the guests will be Professor John Mew and ENT surgeon, Mr. Perry, and Susan Shea, a pediatric dentist. So Mr. Perry Burston will be talking about ENT surgeons and how it relates to dentistry. And Dr. Susan Shea, who is a pediatric specialist, will also talk about a little bit about the advanced program where I mentor dentists in the first few steps that it takes to get them from orthodontics to postural orthodontics into eventually orthotropics.
Yes, very good. So we'll put a link in there to Simon's course. As I said, I'm not teaching at the moment. I've got too much on. I don't suffer fools very well. And if you want to come and lecture, you want to be taught by me, top tip is be taught by Simon first. You know, Simon's a great lecturer. He's really methodical. He's got the patience of a saint, which I don't have. And he will get you to the point where you will get more out of coming to see me, more out of what I can teach you. I also want to say, and that's another link I'll put underneath, please do come to our conference, the symposium in Poland on the 22nd and 23rd of September, where you'll also hear Simon speak, and myself as well, and my father. And there you'll meet, you know, there's no, if you want to get into something, go to the symposium and go on a course. That's how you get good at it. We would appear to be gaining the best facial changes ever achieved by anyone in the planet or any method in the planet. And literally, I've got a challenge out there for anyone who thinks they do get better methods. I want to be proven wrong. Please prove me wrong. Please show me what I can learn from you. And members of the public that might watch this, and I know I have a lot of members of the public come and watch my videos here, go to your orthodontist, go to your dentist, tell them, come to these courses. That's how we gain change. You go to them. If you want a good clinician, it doesn't matter about a dentist or an orthodontist, whoever you want, if you've got someone in your area you like and you want this treatment for your child, you get them to sign up. That's how you're going to get better treatment for your child. That's your investment in this, helping disseminate this work to help yourself and your family. Literally, thank you very much.
Thank you so much.